Hello students, welcome to Pathophysiology. I am Əliyeva Aida from Department of Pathophysiology. Let's continue to our distant lectures. The topic of our lecture today is Pathophysiology of Respiration. Firstly, I would like to introduce you the plan of lecture. At the beginning, we will talk about respiratory insufficiency, which closely connected with disturbance of pulmonary ventilation, disturbance of alveolar diffusion, disturbance of pulmonary perfusion, then disturbance of regulation of breathing, and about types of dyspnea, then acute lung injury, acute respiratory distress syndrome, asphyxia, and at last obstructive and restrictive lung diseases. Before the explanation of causes of respiratory insufficiency, let's give the definition. Which state of the body we consider as a state of respiratory insufficiency? The pathological state in which saturation of blood by oxygen and removal of carbon dioxide are not ensured is called respiratory insufficiency. This change leads to the development of hypoxia and depletion of energy reserves of the body. It may develop primarily as a result of disorders in the external respiration or secondarily due to pathology of the cardiovascular system, blood system, and others. Now, the cause of respiratory failure may be obstruction of the airways, a decrease in the respiratory surface of the lungs, thickening of the alveolar capillary membranes, diseases of the bronchi and lungs, accompanied by impaired lung perfusion. Pathologies not directly associated with the lungs diseases, for example, damage to the respiratory center, impaired innervation of the muscles of the breathing, can also lead to the respiratory failure. Three degrees of respiratory failure are distinguished. In the first degree, the partial pressure of oxygen in arterial blood doesn't fall below 70 mm mercury. Normally, it's about around 96-98 mm hydrogen. The signs of respiratory insufficiency appear here during physical work of a moderate severity. In respiratory failure of the second degree, partial pressure of oxygen is in the range of 70-50 mm mercury. In this case, the body's need for oxygen at rest is ensured by compensatory mechanisms. But when patients perform light physical work, dyspnea occurs. In respiratory failure of the third degree, partial pressure of oxygen is below 50 mm mercury. Even in the state of complete rest, dyspnea and cyanosis of skin are observed. Hypoxemia cannot be completely compensated. Organs and tissue undergo deep hypoxia. Depending on the cause, acute and chronic forms of respiratory failure are distinguished. Acute respiratory failure occurs in attacks of bronchial asthma, pneumothorax, asphyxia, and chronic forms occur in pulmonary fibrosis, pneumoconiosis, and other pathologies. According to the pathogenesis, we distinguished hypoxemic and hypercapnic types of respiratory failure. The main manifestation of damage to the lung parenchyma, impaired perfusion, and alveolar diffusion is hypoxemia. Hypoxemia, is a low oxygen concentration or lowered partial pressure of oxygen in arterial blood. And the main manifestation of airway obstruction, weakening ventilation, is hypercapnia. It should be noted that both of them, hypoxemia and hypercapnia in chronic lung diseases with a long course, develop in a large extent. Hypoxemia and hypercapnia are clinically manifested, such as dyspnea and cyanosis. In acute respiratory failure, the gas composition of the blood changes rapidly within a few hours or days, and time for compensatory mechanisms is limited. If acute respiratory failure accompanied by hyperventilation, it results on development of hypoxemic type, and respiratory alkalosis develop due to hyperventilation. Thus, during hyperventilation through the lungs, carbon dioxide is rapidly excreted, and kidneys can't compensate acid-base balance for a short time. And in acute respiratory failure, which is accompanied by hypoventilation, hypercapnic type develops, where respiratory acidosis occurs during a short time. Now, the chronic type of respiratory insufficiency. Chronic respiratory insufficiency develops gradually. It takes months, years. There is enough time to mobilize the compensatory capabilities of the body. It may be accompanied by hyper or hypoventilation, depending on the kind and localization of damage. For example, if disease is here accompanied by hyperventilation, to prevent hypoxemia and gas change, kidney can compensate for a long time acid-base balance. We talked about acidogenesis and ammoniogenesis in kidney in the first semester. Thanks to this function, kidney take a great role in the compensation of the gaseous or respiratory types of pH changes of the body. Also here, the stroke volume of heart increases, erythropoiesis and hemoglobin synthesis are accelerated. Gradually, these mechanisms are depleted, and compensatory hyperventilation of the lungs cannot prevent hypoxemia, and hypoxia occurs. Anaerobic metabolism is enhanced, which leads to the metabolic acidosis. The main signs of respiratory failure are dyspnea, tachycardia, cyanosis, increasing of respiratory movements, polycythemia, and etc. Dyspnea develops by the following ways. The first, due to acidosis that develops as a result of hypoxia. An increase in the content of hydrogen ions has an irritating effect on vascular chemoreceptors and the respiratory center. Second, due to hypercapnia, carbon dioxide increases the excitability of respiratory center. The second sign is tachycardia. Tachycardia develops by the reflex way. As a result of hypoxemia and acidosis, chemoreceptors located in the reflexogenic zones of aorta and carotid sinus are irritated. These impulses are transmitted through the afferent fibers to the sympathetic nuclei of medulla oblongata, and reflex tachycardia occurs. The next sign is increasing of respiratory movements, also manifests the respiratory insufficiency. Normally, in the resting state, the diaphragm takes a main role in the breathing, but acceleration of the ventilation increases respiratory movements, and even additional muscles of respiration, intercostal muscles, join to respiration and enforces their activity. The next is cyanosis. Cyanosis due to the fact that as a result of weakening of blood flow in the tissue, oxygen consumption is accelerated, and the content of carbon dioxide and the reduced form of hemoglobin in the blood also increase. Polycythemia, hypoxemia that develops respiratory failure, compensatorily to the acceleration of hematopoiesis, erythropoiesis, and increase in blood cells. Disturbance of ventilation manifests itself in the form of hypoventilation, and uneven ventilation. Hyperventilation is an increase in rate and depth of ventilation. The causes of hyperventilation include any pathological process that cause hypoxemia. For example, a decrease in the oxygen content in the air, anemia, heart pathology, and etc. It may occur in neurosis, emotional stress, brain tumors, cerebral hemorrhages, diabetes mellitus, uremia, the effect of certain drugs, acidosis, and etc. In case of decreasing of respiratory surface of the lungs, pneumonia, pulmonary edema, and others, hyperventilation occurs compensatory. Hypoventilation means decreasing of rate and depth of ventilation. We will talk about this in the next, but now in brief about uneven ventilation. What does it mean, uneven ventilation? Uneven ventilation is observed during decreasing of elasticity of the alveoli. For example, in emphysema, impaired bronchial obstruction, for example, bronchial asthma, and the formation of exudate in the alveoli, for example, during pneumonia. Moreover, in the part of lungs that is involved in the pathological process, ventilation decreases and the healthy part of relatively increases. As you see here, hyperventilation is accompanied by hypocapnia, gaseous alkalosis, and hypocalcemia. During alkalosis, the dissociation of oxyhemoglobin slows down. The dissociation curve of oxyhemoglobin shifts to the left. Tissue cannot absorb oxygen, and compensation of alkalosis to the protein buffer system results in hypocalcemia. Clinical signs that develop during hyperventilation are associated with hypocapnia, alkalosis, and hypocalcemia. So, hypocapnia weakens the excitability of respiratory center and causes spasm of cerebral vessels. Here, clinical symptoms such as excitement, insomnia, impaired attention and memory, dizziness are observed. As a result of hypocalcemia, the activity of cardiovascular system is disturbed, arrhythmia, hypotension develop. At the same time, patients have numbness of the limbs, paresthesia, an increase in neuromuscular irritability, convulsions, laryngospasm as a result of tonic convulsions of the arm muscles, Trousseau syndrome appears. In severe cases, respiratory muscles paralyzes and death may occur. In alveolar hypoventilation, gas change between the pulmonary alveoli and atmospheric air decreases. Hypoxemia, hypercapnia, and gaseous acidosis develop. Under these conditions, the dissociation of oxyhemoglobin is accelerated, displacement of the dissociation to the right, and signs of severe hypoxia occur. Alveolar hyperventilation can occur for the following reasons. The first, weakening of the excitability of respiratory center, reducing the partial pressure of carbon dioxide in arterial blood, alkalosis, increasing blood pressure, cause hypoventilation due to decrease in the excitability of the respiratory center. Sometimes, during severe pain, especially in the chest injuries, inhibitory effects, afferent effects increase, and these lead to the weakening of ventilation. The weakening of respiratory center also occurs with damage to the brain tissue, cerebral atherosclerosis, brain injuries, swelling, and brain tumors. The second is damage to the respiratory muscles and their nerves innervating. Inflammation, autoimmune injuries, for example, myasthenia gravis, and traumatic injuries of the muscles involved in the breathing lead to the restriction of respiratory movements. Inflammation, paresis, and paralysis of nerves innervating the respiratory muscles with botulism, tetanus, also lead to restriction of the respiratory movements. Among these pathologies, special place is occurred by damage to the diaphragm and phrenic nerve. In paralysis of the phrenic nerve, paradoxical respiration occurs. During respiration, the diaphragm rises up, and exhalation, it goes down, and which prevents the air from entering and leaving. Sometimes paradoxical breathing is accompanied by an asymmetry in the movements of the right and left halves of the chest. This is called respiratory dissociation or Grocco-Furgoni breathing. Grocco-Furgoni breathing can be observed with brain tumors, severe cardiovascular accident. And the next is hypoventilation associated with the thoracodiaphragmic pathology. This occurs in diseases accompanied by a restriction of movements of the chest and diaphragm. This includes congenital defects of the chest, for example, rickets, kyphosis, lordosis, scoliosis, arthritis of the costal joints, as well as trauma of the chest, ribs, fractures, and etc. In these conditions, it is difficult to tore the chest. Preventing the expansion and contraction of the lungs becomes the cause of hypoventilation. Restriction of the diaphragmatic movements is also observed in ascites, excessive obesity, and intercostal myalgia. And at last, hypoventilation associated with bronchi and lung diseases. It can be observed in chronic bronchitis, bronchoectasias, bronchial asthma, pneumonia, tuberculosis, pneumosclerosis, atelectasis, emphysema, pleuritis, pneumothorax, hydro, and hemothorax. Obstructive and restrictive types of hypoventilation distinguished by the development mechanism of alveolar hypoventilation. The obstructive type of hypoventilation develops when there is any problem in the movement of the air in the airways. The obstruction can be both the upper and lower parts of airways. The lumen of upper respiratory tract can be blocked by the foreign body, various fluids, for example, water, sputum, vomit, or tumor. In obstruction of the upper respiratory tract, inhalation means inspiration becomes difficult and inspiratory dyspnea occurs. In pathologies accompanied by obstruction of the lower parts of the respiratory tract, for example, bronchial asthma, expiration becomes difficult and expiratory dyspnea occurs. Due to obstructive hypoventilation, the exhalation act is more disturbed and the residual volume of lungs increases and significantly decreases the Tifno index. As an example of diseases characterized by airway obstruction, chronic bronchitis, bronchial asthma, emphysema, bronchiectasis can be listed. We will talk about them in the following slides. Restrictive type alveolar hypoventilation occurs when the ability of the lungs to expand becomes difficult. This type of hypoventilation is associated with pulmonary and extrapulmonary problems. Pulmonary pathologies that are accompanied by the restrictive type of hyperventilation include pneumonia, tuberculosis, a tumor of lung resection, pulmonary edema, pneumosclerosis, atelectasis, and etc. Extrapulmonary causes include pleural pathology, pleuritis, pneuma, hydro, hemothorax, process that disturbs the movable of diaphragm, ascites, peritonitis, damage to the phrenic nerve, and etc. Disorders of the other respiratory muscles, myositis, polynephritis, tetanus, botulism, and others. Difficulties of the chest excursion, traumatic injury of chest, intercostal myalgia, kyphosis, lordosis, scoliosis, and etc. In restrictive type of the hypoventilation, the inspiration is most damaged and inspiratory dyspnea develops. As a result, the tidal volume, vital capacity of lungs decrease. However, due to the fact that the expiratory volume decreases slightly, the Tifno index remains at a normal level or may increase. Alveolar diffusion provides the transition of oxygen from the alveolar cavity to the pulmonary capillaries and carbon dioxide on the opposite direction. In the initial part of pulmonary capillaries, the partial pressure of oxygen in the blood is less than in alveolar air. Red blood cells are enriched with oxygen as they move in the capillaries. The diagram below shows you how the partial pressure of gases change in the blood before and after flowing to the lungs. In the blood flowing to the lungs, partial pressure of the oxygen is 40 mm of mercury, and in the blood returning from the lungs to the heart, 100 mm hydrargyl. And partial pressure of the carbon dioxide of the blood in the initial part of the pulmonary capillaries is 46 mm mercury, and in the final part 40 mm hydrogen. The volume and rate of alveolar diffusion depend on various factors. The first, the difference in gas gradients of oxygen and carbon dioxide in the alveolar air and pulmonary capillaries. At a low partial pressure of oxygen in the atmospheric air, alveolar diffusion weakens. The second is area of diffuse surface of the lungs. It's approximately 200 meters square. In pneumonia, allergic alveolitis, pulmonary edema, emphysema, atelectasis, sclerotic change in lungs parenchyma, the area of diffuse space surface of the lung and the volume of alveolar diffusion are reduced. The third, the thickness of the alveolar capillary membranes. Normally, the thickness of this membrane is 0.2 till 2 microns. In lung diseases, for instance, in respiratory distress syndrome of newborns, the thickness of alveolar capillary membrane increases and the diffusion of gases through this membrane decreases. The fourth is the last is molecular weight of diffused gases and their solubility. It's known that the diffusibility of carbon dioxide is 20 times higher than oxygen. So, normally within 1 minute, 15 milliliters of oxygen and 300 milliliters of carbon dioxide diffuse through the alveolar capillary membranes. And therefore, with most respiratory diseases, oxygen diffusion is mainly disturbed and hypoxemia develops against the background of normocapnia. A disorder of the diffusion of carbon dioxide occurs in severe damage to alveolar capillary membranes. For example, adult respiratory distress syndrome, and this is accompanied by hypercapnia and hypoxemia. Lung perfusion may be impaired for these three reasons. The first, decreased pressure in the right ventricle. Right ventricle failure, decreased venous blood flow to the right side of the heart during shock, collapse, and etc. The second is increased pressure in the left atrium, left ventricle failure, mitral stenosis, for example, and at last increased resistance in the pulmonary vessels, reflex spasm, thromboembolism of the pulmonary arteries, and others. Disturbance of the lung perfusion may lead to the pulmonary hypertension, which characterized by increased pressure in the vessels of pulmonary circulation. The next slide will show us the reasons and outcome of pulmonary hypertension. Pulmonary hypertension may develop by the reflex pathways, Euler-Liljestrand reflex and Kitaev reflex. Euler-Liljestrand reflex occurs during decreasing of the oxygen content in the alveolar air. For example, during hypoventilation, lowered oxygen concentration in alveolar air causes an increase in tonicity of pulmonary arterioles. These arterioles are squeezed and pulmonary hypertension occurs. The next is Kitaev reflex, increasing pressure in the left atrium, for instance in the mitral stenosis, or suddenly and sharply increasing of arterial pressure in arterial hypertension cause spasm of pulmonary arteries. Besides of these reflexes, an increase in intra-alveolar pressure, for example in obstructive diseases accompanied by expiratory dyspnea, as a result of prolonged expiration, pressure in the alveoli rises. In this case, the resistance of the pulmonary vessels increases and causes the pulmonary hypertension. Pulmonary hypertension initiated the hypertrophy of the muscles of right heart. This is called core pulmonary. Prolonged hypertension restricts lungs excursion. Restrictive hypoventilation and inspiratory dyspnea occur. All this may lead to the development of pulmonary edema. The development of pulmonary edema depends on the type of pathology that caused it. So, in left ventricle failure, crisis of arterial hypertension, pulmonary edema develops by hydrostatic mechanism. In clinic, this is called cardiogenic edema of lungs. In nephrotic syndrome, oncotic pressure sharply decreases as a result of proteinuria and hypoproteinemia, and pulmonary edema develops here according to the oncotic mechanism. And when a large volume of fluid is transfused into the body, pulmonary edema may occur also. In exogenous and endogenous intoxications, in the first type of allergic reactions, infectious and inflammatory diseases, process of lungs, mediators are released. These mediators increase the permeability of pulmonary capillaries and edema develops here according to the membranogenous mechanisms. Pulmonary edema develops in two stages. The first stage called interstitial edema, the second is alveolar edema. At first, the liquid part of the blood passes from the pulmonary capillaries into the interstitial tissue space, and then fluid enters the lumen of alveoli. In interstitial edema, the dyspnea develops even during normal physical exertion. In alveolar edema, the condition is even more complicated. The patient has respiratory failure even at rest, and he takes the position of orthopnea. In this case, the patient is forced to remain upright, unable to sleep, forced to fall asleep in a sitting position, because in a horizontal position, blood volume in the lesser circulation increases, heart function becomes more difficult, and congestion in the lungs is increased even more, and asphyxia begins. Asphyxia, as you know, a terminal stage of respiratory failure. It results in the breathing arrest. If emergency measures are not taken in time, the patient dies from asphyxia. Impaired respiration may be associated with disorders in the regulation of breathing. It's connected with change in central mechanism, afferent and efferent mechanisms of breathing. As you know, the respiratory center is located in the medulla oblongata. Here, the centers of the inspiration and center of expiration are distinguished, and pneumotoxic and apneistic centers located in the pons. These centers constantly receive impulses from peripheral, chemo, baro, mechanoreceptors and from cerebral cortex. The peripheral receptors involved in the regulation of respiration are located mainly in sinocarotid region, the aorta, chemo and baroreceptors, and the smooth muscles of the respiratory system, mechanoreceptors, between the epithelial cells of the respiratory tract, irritant receptors, and G receptors in the interstitial area. It's known that receptors of vagus nerve are located in the wall of the alveoli. During a sharp increase in pressure in alveolar wall, the irritation of these receptors leads to the change in sequence of inspiratory and expiratory acts and the depth of breathing. This is called Herring-Brier reflex. Inflammation, thickening of the alveolar wall, interstitial or alveolar edema increase the tension of the alveolar wall. Irritation of receptors located here leads to the more rapid change of inspiration by exhalation according to the Herring-Brier reflex. As a result, superficial and frequent rapid breathing occurs. Disturbance of the central mechanisms of regulation of the respiration linked with organic change in the brain, for example, tumor, edema, hemorrhages here, functional disorders, for example, during neurosis, psychosis, cerebrovascular pathology, cerebral atherosclerosis, and even anemia, hypoxia, intoxication of various types, intoxication, poisoning by carbon monoxide, for example, all they change the activity of respiratory center. And lastly, the disorders of efferent mechanisms is associated with inhibition of the arrival of impulses along the efferent ways from the respiratory center to the respiratory muscles. As a result, a decrease in the efferent impulses coming to the diaphragm, the involuntary regulation of breathing is disturbed, and breathing becomes voluntary. Therefore, respiratory arrest occurs during sleeping. At a resting state, in a healthy person, the rate of respiration is 16 till 20 per minute. In the pathological conditions, the following types of respiratory rhythm disturbances are distinguished. The first you see here, tachypnea or polypnea. It's a rapid superficial respiration, mainly observed in pulmonary pathology, for example, during pneumonia, pulmonary edema, atelectasis, acute pain in the chest, and etc. The next is hyperpnea. It's a rapid deep breathing resulting from irritation of the respiratory center in a reflex or humoral way. Occurs in diabetic coma, uremic coma. This is called the Kussmaul respiration. Then the bradypnea is a decrease in respiratory rate, increased blood pressure, hypocapnia, hyperoxia, due to the impulses from baro and chemoreceptors by a reflex way lead to a decrease in the respiratory rate. And at last you see here apnea is a temporary respiratory arrest. It's a stop of the breathing. The cause of apnea can be a sharp decrease in the carbon dioxide content in the blood. For example, after prolonged hyperventilation. Some types of anesthesia, for example, anesthesia by chloroform, barbiturates, and etc. And it has a strong inhibitory effect on the respiratory center, can lead to the respiratory arrest. In some pathological conditions, the rhythm of the breathing is accompanied by regularly recurring apnea. Periodic breathing is called breathing in which the altered respiratory rhythm is replaced by short breaks. Periodic respiration includes chain-stocks breathing and biot breathing. During chain-stocks breathing, the inspiration gradually deepens and accelerates. After reaching a certain maximum level, the amplitude of the respiration begins to decrease gradually, and respiration finally stops. After apnea lasting 30-40 seconds, breathing is restored again. Chain-stocks breathing occurs mainly in pathological conditions leading to brain hypoxia, brain injuries, acute intoxication, decompensated heart defects. During biot breathing, accelerated and deep breathing acts are periodically replaced by periods of apnea. Biot breathing is observed with meningitis, encephalitis, heart stroke, and other pathological conditions. The pathogenesis of periodic breathing is explained with a weakness of the excitability of respiratory center. In this case, the concentration of carbon dioxide in the blood cannot cause excitation of respiratory center, and apnea occurs. Terminal respiration occurs in a terminal state when the body is between life and death. Apneistic and gasping are the types of terminal respiration. Apneistic breathing is characterized by short-term acts of expiration occurring along to prolonged acts of inspiration. In this case, the duration of inspiration is several times longer than duration of the exhalation. So, in a terminal state, the inhibition of the cerebral cortex spreads from the cortex to subcortical nucleus and enriches to pons. the activity of neurons of the pneumotaxis center here disturbed, disrupted. As a result, the change in the acts of inspiration by expiration is delayed. Gasping breathing is characterized by rare acts of inspiration, which gradually weakens. The patient is trying to swallow air, and all muscles of the head and neck participate in breathing. The respiratory movements gradually weaken and finally disappear. Gasping breathing occurs at the agonal state of the terminal state after the terminal pause. It's also called agonal breathing. At this stage, the inhibition process extends to a cerebral cortex, subcortical structures, brainstem, most of the medulla oblongata, and the rare attempts of inhalation are the result of random stimulation of neurons of the medulla oblongata that have retained their activity. Now I would like to give you some information about acute forms of lung injury, then in brief about obstructive and restrictive lung diseases. Acute respiratory distress syndrome, ARDS, is characterized by diffuse damage to the alveolar capillaries and alveolar epithelium. Acute respiratory distress syndrome develops for various reasons, leading to pulmonary edema and acute respiratory failure. By the way, this is a very emerging problem nowadays because atypical pneumonia caused by COVID-19 is complicated by acute respiratory distress syndrome, and patients die for this reason. Two forms of the distress syndrome are distinguished: acute respiratory distress syndrome of adults and newborns, and mainly premature newborns. Acute respiratory distress syndrome in adults is diffuse damage to the lung parenchyma. This syndrome may develop as a result of direct damage to the lungs due to infectious, especially viruses, allergic and inflammatory processes, as well as extrapulmonary pathologies, for example, general infection, sepsis, then pancreatitis, peritonitis, traumatic and bone shock, disseminated intravascular coagulation. All they may lead to the formation, development of acute respiratory distress syndrome. In diffuse damage to the lung, the alveolar epithelium necrotizes and permeability of alveolar capillaries sharply increase, and alveolar edema develops. Very important pathogenic point here, dysregulation of acute inflammatory response, the occurrence of an imbalance between pro and anti-inflammatory mediators. Alveolar macrophages and neutrophils play an important role in this imbalance. Macrophage-activated neutrophils immigrate and accumulate in the alveoli. These cells secrete a large amount of the inflammatory mediators, for example, leukotrienes, platelet-activating factors, proteases, interleukin-1, interleukin-8, tumor necrosis factor, and others. The alveolar epithelium is damaged and necrotized. The synthesis of surfactant ceases because of the destruction of the type II epithelial cells in the wall of alveolar. The alveolar are closed and atelectasis develops. Excessive activation of the neutrophils can be inhibited by anti-inflammatory mediators, for example, interleukin-10, endogenous proteases, antioxidants, and etc. And the damage is deepened. Due to the increased permeability of alveolar capillaries, the filtration of plasma proteins increases. The hyaline substance that consists of these proteins and the necrotic epithelium sediments on the wall of alveoli. It thickens, and which lead to the disruption of the alveolar diffusion, and severe hypoxemia develops. That's why oxygen therapy is usually ineffective here. If urgent measures are not taken, acute respiratory distress syndrome is fatal. Acute respiratory distress syndrome of newborns is observed usually in premature infants. It's also called hyaline membrane disease. The main cause of this disease is surfactant deficiency arising in the neonatal period. Asphyxia is a severe form of respiratory failure. In asphyxia, the process of oxygen transfer into the blood and removal of carbon dioxide from the body become impossible. Asphyxia can occur during squeezing of airways from the outside, for example, by tumor, drowning in the water, getting amniotic fluid into the airways of the fetus, edema of larynx in diphtheria, measles, and other infections, bronchospasm in attacks of bronchial asthma, quinquedema, and other allergic reactions. All they may be accompanied by asphyxia. In these pathologies, the asphyxia 4 stages are distinguished. You see the main characteristics of each stage in this slide. The first stage is characterized by an acute increase in the activity of the respiratory center and inspiratory dyspnea occurs. The second stage is characterized by weakening of the respiratory center and expiratory dyspnea occurs here. In the third stage, breathing stops for 1-2 minutes. Respiratory arrest is associated with a delay in the activity of respiratory center. At this time, blood pressure and pulse are significantly and actually reduced, and the patient lost consciousness. And at the fourth stage, reflexes are lost, the pupils sharply dilate, blood pressure decreases significantly, gasping breathing occurs. Then respiratory center is paralyzed and death occurs. And emergency measures must be done to save the patient's life. As an example of diseases characterized by airway obstruction, chronic bronchitis, bronchial asthma, emphysema, bronchiectasis can be cited. Chronic bronchitis is a chronic inflammatory process that develops as a result of prolonged, regular irritation of mucous membrane of the respiratory tract. It develops after acute bronchitis, often occurs as an independent disease. Chronic bronchitis is mainly a disease of the smokers. Prolonged cough and sputum production, obstruction, and hypersecretion of mucus are characteristic. In chronic bronchitis, obstruction occurs at the level of the trachea, bronchi, and bronchioles. Their wall undergo deformation. In the deformation of their wall or bronchi extension occurs. This is called bronchiectasis. A strong and progressive cough increases pressure in the lumen of alveoli. It causes atrophy of altered alveolar walls and intraalveolar septa, and emphysema develops. Emphysema is characterized by obstruction of terminal bronchioles and destructive change in the walls of distal part, expansion of the alveolar cavities. In emphysema, as a result of destructive change in the walls of alveoli, their elasticity decreases and intraalveolar septa undergo to the atrophy. They turn into the large airbags, and expiratory dyspnea occurs. An important role in the mechanism of emphysema plays an imbalance of the protease-antiprotease and oxidant-antioxidant system. Chronic irritation of the alveolar wall attracts neutrophils and macrophages here. They secrete an excess amount of the elastase, collagenase, and activated forms of the oxygen. Moreover, if there is a lack of antiproteases, for example, alpha-1 antitrypsin, the proteases are not neutralized. They expose the destruction of the wall of the alveoli. Therefore, people with a hereditary defect in the alpha-1 antitrypsin synthesis are prone to the emphysema. In the development of this pathology, smoking is a great importance. Normally, the lungs have a large antioxidant reserve, superoxide dismutase, glutathione system, and others. However, due to chronic exposure of the cigarette smoke, this reserve is depleted and antioxidant deficiency occurs. Bronchial asthma is a chronic inflammatory disease of the airways that is characterized by attacks of bronchospasm, airway obstruction, and expiratory dyspnea. Hyperemia, edema, and spasm of bronchioles lead to the narrowing of its lumen and increase in airflow resistance. Bronchial asthma is a disease with a hereditary predisposition. The allergic component plays an important role in its pathogenesis. The disease is associated with the sensibilization of the body to various allergens and the hypersensitivity reactions that occur when this allergen is reintroduced into the body. Allergens that cause asthma include domestic and household dust, pollen, allergens from domestic animals, for example, wool, hair, then food allergens, and etc. According to the pathogenetic mechanism, the development of the atopic and the non-atopic forms of bronchial asthma are distinguished. The basic of the pathogenesis of atopic asthma is the type first hypersensitivity reactions. We have studied the mechanism of these reactions in the first semester. In the pathogenesis of non-atopic asthma, the allergic immune mechanism is not involved. In patients with non-atopic asthma, immunoglobulin E is synthesized within normal limits. However, activation of eosinophils and an increase in release of mediators from them are also characteristic for this type of asthma. The reason for development of this form of asthma is a hyperallergic inflammatory reaction of the body to the respiratory tract infections, mainly it's the viral infection, then cold, harmful substances contained in the air. As a result of such hyperreaction, bronchospasm, bronchial obstruction occurs. Chronic irritation and inflammation of the bronchial mucosa leads to the decrease in the threshold of irritation of subepithelial parasympathetic receptors. Moreover, and even the weak irritation becomes the cause of the excitation of these receptors and reflects bronchospasm. Depending on the type of etiological factor, infections and non-infections types of bronchial asthma are distinguished. For example, drug asthma, occupational asthma, and others. The pathogenesis of both infection and non-infection asthma can be associated with allergic, pseudo-allergic, and non-allergic mechanisms. For example, aspirin-related asthma related to drug-induced asthma develops according to the pseudo-allergic mechanism. The restrictive type of respiratory diseases include pneumonia, atrictasis, pneumothorax, and etc. Pneumonia is an inflammatory process of various origins that develops in the lungs. Typical and atypical non-bacterial pneumonias are distinguished. Typical pneumonia is caused by bacteria, for example, pneumococcus, streptococcus, staphylococcus, klebsiella, and etc. These are extracellular microorganisms and that multiply in the cavity of the alveoli and lead to the development of an inflammatory process here. In this case, a strong exudation and alveolar infiltration occurs. Atypical pneumonia is caused by mycoplasma, chlamydia, and a number of the viruses, adenoviruses, coronaviruses, the virus of influenza, for example, bird fly, pig or swine fly, and etc. These infectious factors passing from the alveolar cavity to the interstitial region multiply here. The course of diseases is atypical, the course of the pneumonia here is atypical, and it complicates in acute respiratory distress syndrome, and usually the outcome of this is fatal. Atelectasis is a pathological process characterized by collapse of the alveoli and the closure of their lumen. Atelectasis is not an independent disease. It's not the nosological unit, but it is a pathology that can develop as a result of various diseases of the respiratory system. According to the development mechanism, resorption, compression, and contraction types of atelectasis distinguished. The first is reception atelectasis develops as a result of blockage of the lumen of the bronchi by the foreign body, tumor tissue, thick sputum, spasm, which makes it impossible for air to enter the alveoli. In this case, the air remaining here is resolved and the lumen of the alveoli closes. The next type, the compression atelectasis, occur when the lungs are compressed from outside. The reason for this may be the accumulation of fluid or air in the pleural cavity, for example, during hydropneumothorax. And contraction atelectasis develops as a result of growth of connective tissue in the lungs parenchyma during pneumosclerosis, during fibrosis of the lungs, and this is an irreversible process.
Hypoxia is a typical pathological process connected with insufficient oxygen supply by tissue or inadequate utilization of oxygen by tissue. Causes of oxygen deficiency. Oxygen deficiency in inspiratory air and abnormal ventilation and diffusion and form central hypoxemia. Decreasing transport capacity, and this process develops in the anemia, and erythrocyte is decreasing, and circulatory failure, vasoconstriction, and form peripheral hypoxemia. Increasing oxygen affinity of hemoglobin, abnormal diffusion in tissue, accumulation water in the extracellular space or interstitial tissue, form edema, abnormal oxygen utilization, and change normal function cell. Classification of hypoxia, and depending on the etiology, exogenous hypoxia have two types, and hypobaric. In the hypobaric decreases oxygen and barometric pressure, and normobaric decreasing oxygen but barometric pressure is normal. Endogenous hypoxia has several forms: respiratory form, circulatory form, hemic form, tissue, and mixed form. Depending on the level, has a local and general form. Depending of the duration, superacute, acute, subacute, and chronic form. Exogenous normobaric hypoxia occurs in confined space, impaired air ventilation, hyperventilation. Exogenous hypobaric hypoxia occur in mounting and attitude sickness, and etc. In exogenous hypoxia and form arterial hypoxemia, and form compensatory hyperventilation, finally form hypocapnia. In hypocapnia, the dissociation curve of oxyhemoglobin shift to the left. The connection of hemoglobin with oxygen increases. Oxygen transfer to tissue is difficult. is difficult, and respiratory alkalosis is observed, and other form metabolic acidosis, and with hypocapnia a spasm of the vessel of the heart and brain is observed. In same causes, exogenous hypoxemia is accompanied by hypercapnia and acidosis. In the acidosis, dilation of the cerebrovascular vessel. In acidosis, the dissociation curve of oxyhemoglobin shift to the right, and the connection of hemoglobin with oxygen decreases. And respiratory type hypoxia, there are form arterial hypoxemia, hypercapnia, acidosis, causes violation of alveolar ventilation in obstruction of the upper respiratory tract, and in restrict disorders and formation atelectasis, pneumonia, pneumosclerosis, and hydrohemothorax, and etc. Respiratory dysregulation and influence in the drug, stress factor, neurosis, and etc. Violation of the relationship between ventilation and perfusion. This process develop in emphysema, bronchospasm, and etc. And injure lung perfusion and disorders of lung diffusion. Respiratory hypoxia, in the respiratory hypoxia and decreasing of partial pressure oxygen in arterial and venous system, increasing carbon dioxide in arterial system, decreasing pH in the early period from gas acidosis, and in the late period and metabolic acidosis, and decreasing of oxyhemoglobin in the arterial and venous blood system. The curve of dissociation of oxyhemoglobin is shifted to the right. Normal oxyhemoglobin in blood system and 98 and 100%. Venous blood oxyhemoglobin is 40%, and arterial-venous difference is 60%. Hypoxia of the cardiovascular type causes hypovolemia, failure heart system, decreasing vascular tone, and disorders microcirculation, and there are local and systemic circulatory hypoxia. Circulatory hypoxia in the form decreasing of partial pressure oxygen in venous system. In the arterial system don't change, increasing of artery-venous difference and development of non-gaseous alkalosis, decreasing concentration of oxyhemoglobin in the venous system. And hemic hypoxia, at the same time the oxygen capacity of the blood decreasing. It is observed with anemia, hyperemia, with inactivation of hemoglobin. Hemoglobin inactivation absorbed when connection of hemoglobin with carbon monoxide and form carboxyhemoglobin. The curve of dissociation of oxyhemoglobin is shifted to the left. Formation of methemoglobin, and ferrum 2 is oxidized and converted to 3 form, decreases oxyhemoglobin in the venous system. Under the influence of the methemoglobin and hemic hypoxia is created. Methemoglobin forms, for example, if hemoglobin connected with nitro compounds and bind with amino compounds and dyes material and oxidizing agent form and drugs. And when hemoglobin is inactivated, a shift of the oxyhemoglobin dissociation curve to the left is observed. The arteriovenous oxygen difference decreases. And in the hemic hypoxia, decreasing of oxygen in the arterial blood system, and partial pressure oxygen in the arterial blood system is normal, decreasing oxygen in the venous system, decreasing volume of oxygen in the venous system, and develop of non-gaseous acidosis, and decreases arteriovenous difference in the venous blood system. And there are change of oxyhemoglobin dissociation, curves shift dissociation oxyhemoglobin left and right part. In the left part occur if decreasing of body temperature, alkalosis, hypocapnia, thalassemia, and decreasing 2,3-diphosphoglycerate in erythrocyte. If in the right occur if increasing the body temperature, acidosis, hypercapnia, increasing of 2,3-diphosphoglycerate in the erythrocyte, and etc. Histotoxic hypoxia or tissue hypoxia occur as a result of oxygen utilization violation observed with inactivation of respiratory enzymes. Cyanides reduce the activity of cytochrome oxidase and uricine alcohol, inactivated cell dehydrase, and cuprum, mercury, argentum. They also inactivate tissue enzymes, inhibition of biological oxidation and phosphorylation in deficiency of vitamin B12, 2, and pp. High and low temperatures, radiation factor, the effect of exogenous poison, toxic element, free radical, and etc. And in the histotoxic hypoxia, increasing partial pressure oxygen in the venous system, increasing volume of oxygen in the venous blood system, normal partial pressure and volume oxygen in the arterial blood system, development of non-gaseous acidosis, and decreasing of arterial venous oxygen deficiency difference, and etc. Overload type hypoxia occurs with a prolonged increase in the function of tissue and organs. In this case, it is observed decreasing of partial pressure oxygen in venous system, increasing carbon dioxide in the venous system, reduction of oxyhemoglobin in venous system, increasing arteriovenous difference oxygen, and etc. And subtype type hypoxia occurs when there is a difference of biological oxidation substances in the cells, and glucose with a deficiency of fatty acid in the myocardium. In this case, if observed oxygen is decreasing in the venous system, increasing oxyhemoglobin in the venous system, and partial pressure oxygen and oxyhemoglobin in arterial system and normal, reduced arteriovenous difference on oxygen and form acidosis. And sequence of neuronal resistant to the hypoxia, for example, peripheral nervous nodes and spinal brain, medulla oblongate, hippocampus and cerebellum and cerebral cortex. A mixed type of hypoxia is a combination several type of hypoxia, for example, with traumatic shock, circulatory and respiratory. For example, microcirculation in the lung system is disorders and form shock lung, and with severe anemia of massive formation of carboxy or methemoglobin, hemic and circulatory hypoxia develop, and nitrate poison causes hemic and tissue hypoxia, barbiturate poisons cause respiratory and tissue hypoxia, and there are local and general hypoxia is observed. And there the slide shows the rapid adaptation reaction that develop in the body during acute hypoxia. And next slide shows the delayed adaptation reaction that develop in the body during chronic hypoxia. Thanks for attention. Take care.